office. Okay.
Okay.
Now, all right. Welcome, and thank you all so much for joining us. This is Sheila Kilbane. I'm an integrative pediatrician here in Charlotte, North Carolina, and I have a practice called Infinite Health. It's right in Dilworth, and I do all integrative medicine. So that means I help the kids who maybe are doing all that conventional medicine recommends, and if they're still struggling, then they come and see me and we work through nutrition and gut health and help to get them back into balance and help support their immune system, which is also extremely helpful at this time while we're in the middle of a pandemic. And we started doing a Q&A series right when the pandemic hit, just to help keep people informed as much as we could. And one of them we did with my dear friend, Dr. Smolen, who is a retired pediatrician, who I met when one of my friends was having a baby, and I was doing a job, it's called locum tenens, where you go and fill in at other practices. And he was one of the pediatricians there. And every night we would sit after we finished seeing patients and we would talk and talk and talk. And Dr. Smolen has an amazing podcast called Doc Smo and a website, it's called docsmo.com, that recently won an award. And he's been doing it for the past 11 years, you said?
Well, I'm just starting my 11th year.
11th year. So I'm super excited, and we had so much fun last time when we did our webinar, and so we decided to do another one. We're like frickin' frack. We're like because when we started, I mean, he's very much conventional pediatrics, and so we started, and we would do podcasts about dairy and nutrition, and you were, to say the least, a bit skeptical. No?
Yes.
Okay. It's a fair statement.
2 yeses there. A double yes.
But he kind of shifted and came around, and so anyway, we learn from each other, and we laugh a lot while we're getting everything prepared. So what we're going to go through tonight, I'm going to just read the outline, and he and I are just going to kind of talk back and forth. And you all are, if you haven't heard Dr. Smolen, you're going to love him. He is an absolute wealth of knowledge. So tonight we're going to talk about COVID in kids. What do the numbers really tell us? And it's the information that we know today. As most of you know, the information is changing extremely quickly. And so we're going to talk about that multi-inflammatory systemic issue that kids are getting. It's that Kawasaki's like illness. We'll look at the numbers of that. We're going to compare the numbers of COVID to other causes of death in the US. And then we're going to talk about kind of the biology and the characteristics of the SARS-CoV-2, which that's the virus, and COVID-19 is the actual illness. And we're going to talk about the
A lot of people get that confused.
Yeah, and we'll talk about that. We'll address that more, so that makes sense. It's similar to HIV versus AIDS. So we'll just clarify that. And then we'll talk about testing, vaccines and prevention, some of the treatments, and then we'll kind of give you our conclusions. And one of the things I do love about Dr. Smolen also is that he is the #1 at talking about getting things practical and having those good sound bites that we need, the take-home lessons. So let us begin. And so with the numbers, when we're going through the numbers, I'll get this started and then we'll move on. So only 2% of the COVID cases have been in kids, and only 0.6% of the cases have become critical, so maybe had to be in the intensive care unit, you get oxygen. It definitely, as most of you know, it manifests more severely in adults, and children who become symptomatic, it may be a cough, fever, fatigue. And then in rare cases, children will develop this multi-system inflammatory syndrome. It's being called MISC, but there have really only been about 200 cases reported in the US out of 73 million children. So if that puts that into perspective.
Well, actually, let me interrupt for 1 second.
Yes, please.
That's children under 18. That's the number I could find. It's a close approximation. But the MISC syndrome is actually defined up to 21. So it's actually a much larger number of very few cases among a very large group of children.
Yes, and that is one of our overwhelming messages that we want to bring home tonight is how rare it is in kids, which thank God, right? We're have enough challenge with this as it is. If the kids were getting sick, that would be even worse. So
Yes.
just some of the Charlotte numbers, we have two, and this is directly from our meeting last night that we had from Dr. Ahmed and Dr. Nazario, what's his last name?
Chaparro.
So they did an amazing presentation for our Charlotte Pediatric Society. And so we're just using some of the numbers that they reviewed for us. So in the Novant Hospital system, of 5,200 kids being tested, 695 were positive. And then at the Atrium system, it's been about 12.8% of the children tested are testing positive.
That doesn't mean sick. That means testing positive.
Yes.
Right?
Do you want to talk a little bit about that too? Because the numbers, how the percents are really not necessarily that accurate because we're just not testing everyone.
Well, I mean, the only way to really know what's happening is to test everybody all at the same time. We can't do that. Too many of us. So we take samples, and then you have sampling error anytime you take a sample. And so people who are sick or people who are very anxious about the situation or whatever are much more likely to be tested. So it's by definition inaccurate, right? We know enough adults have been tested now that we know that about 45% of adults are asymptomatic. So they're not going to go to the doctor asking to be tested because they're asymptomatic. So the numbers are going to get skewed towards more sickness because people without symptoms aren't going to seek medical care. And then about, about 45% are going to have either a mild or a moderate illness, and about 5% are going to have a very severe illness. That's in adults. One thing I learned doing this research, only about 5% of children are asymptomatic. I didn't know that. I thought it was, close to the 50% that we hear in adults, which is actually, I think, really good news, because everybody's fear is that their child will go to school, come home, asymptomatic carrier, go to grandma's house, to be babysat, and grandma has a 6% chance of dying from COVID-19 because she's, 75 years old. That's a lot of people's fear. It doesn't look like that's likely to happen because kids are going to have symptoms generally. There's going to be that little period before they get sick where they shed virus, but they're not going to shed as much as we learned it from Dr. Ahmed. The peak viral shedding is the first few days of sickness. So I think that's actually sort of good. And it's probably good for school attendance as well, because, it's easy to identify kids who are sick. It's not easy to identify kids who are shedding virus and have no symptoms.
Yeah. You and I have talked about this several times about how this is so rare for a virus to not be impacting kids. Kids are usually the little incubators that are spreading it everywhere. So
flu is our model, and when flu hits a community, it comes in through the kids, and then the parents wipe the kids' noses, and then they get sick, and it percolates up towards the people who have the highest risk, which again are elderly people. So that was the whole idea of we're aggressively vaccinating kids down to 6 months of age. Keep it out of the kids, you keep it out of the adult population. That's not what's happening with COVID-19. Kids aren't getting it very much. The germ has a hard time getting started there, and they're not making their parents sick. If anything, it's the other way around. Of the babies who've gotten sick, it's generally almost all the mothers got it first, and then the babies got it, which I find sort of interesting. It's usually the other way around.
Yeah. And then I'm going to just go through a few more numbers about these. So in Charlotte, in our children's hospital in Charlotte, the numbers for COVID, the hospitalizations, and these are also answering some of the questions that you all had sent in on social media. So 37 patients with COVID have been hospitalized, or sorry, 25 hospitalizations since June 1st. And the way that this broke down by age is 15 were less than a year old, 4 were ages 1 to 4, 3 were ages 5 to 9, 8 were ages 10 to 14, and then 7 were greater than 15 years old. And 9 of them had that multi-inflammatory systemic disease. And
Yeah,
in
so you can
North
see that it's
Carolina,
the babies.
sorry, that was in North Carolina, but only one. So it's much less in our community. Sorry, what were you?
Yes, that's the whole state. Only 9 cases. So it makes for great headlines. You know, it sells a lot of magazines. It gets your attention. But we're talking about a very rare syndrome. Put it in perspective, there were about 5,400 cases of Kawasaki's disease a year on average the last few years, and we've had 250 cases of multi-system inflammatory syndrome in children. Much rare. And the other one thing I want to point out in those statistics, Sheila, is that look at the under 1 year of age. That's where the sickness is.
Mm-hmm.
And I don't really understand why, but little babies get infected more than school-age kids, or at least they get recognized to be infected more.
Yeah, so definitely being careful in that population.
Yes, which we always are with babies.
Mm-hmm.
That's what pediatrics is all about, right?
Exactly.
Prevention. Yeah.
Keep the babies healthy. And then some of the things that one of the highest GI symptoms, there was a high prevalence, about 92% of the kids with that multisystemic illness had GI symptoms. And but this inflammation, it can occur 1 to 6 weeks post-infection. And you also, if the kids are having rash, conjunctivitis, which is sort of a redness, inflammation around the eyes, neurologic symptoms, so kind of irritability, fussiness in the younger kids. And it's, so those are they can get swelling in their hands, in their feet.
It's not subtle. You know, it's
yes, right.
Kids are really sick.
Yeah.
You know, everybody, you just take a look at them, anybody would know that they're really sick. Mm-hmm. And it happens not during the infection, but it happens, weeks after the infection. Usually they're not virus positive at the time they present, but there's evidence that they had the infection or somebody around them had the infection. Mm-hmm. Shock is part of the whole thing in a majority, and most of these kids end up in an ICU, but they almost all do well. I mean, they just need supportive care. So it's a post-viral inflammatory disorder. It's an immune thing, not an infection thing. That's the big distinction. And it's rare, and everybody's all hyped up about it. But now that people are like you and I are getting better at recognizing this, we know what to do. We'll recognize it, and the kids will be fine. I think that's generally true.
Yeah, with proper treatment, kids do well. And one of the other, I'll just read a few stats. So what we looked up in Virginia, I don't know if she's on here, but thank you. She grabbed some of these stats for us. So the number of kids, your kids have a higher risk of dying in a car accident than they do of COVID. So about 670 kids under 12 died in car accidents in 2017 in the US. And of the 16 to 18 age group, it was 2,300. So monitor your children's driving abilities as much as you do their quarantining. Car accidents are the leading cause of death in teens in the US. And then cancer, kids have a higher risk of getting cancer. 1,780 kids died of cancer in 2018. The flu was higher, 600 estimated deaths of flu in the 2004 to 2005 season. And suicide, 6,200 adolescents died of suicide in 2017. So mental health. So these are other, we want to pay attention to what's happening, absolutely. But we wanted to just give a comparison of some of the other actual numbers of things. All right, Doc Smo, do you want to talk about the kind of the next section? So we were going to talk about sort of the biology and the characteristics, and then of the difference between COVID-19 versus SARS.
Yeah, it's really quite an interesting subject, and I'm sure most people have heard a lot of this, but this is considered a zoonotic infection, which means it leaped from an animal to humans. And I don't think there's much doubt that it came from bats. Now, whether it was the bats in the wet market that actually infected people, or they took the bats home and did whatever they do to bats and infected people there, or whether, I think the leading theory is that humans go into these caves to collect the bats, and they probably got infected when they went into the caves. And then when they came to the wet markets, then it's a pretty contagious disease, as you'll see in a minute. We're going to quantify that. And then they infected people in the marketplace, and then away we go. And remember, it's exponential. It's the virus is a coronavirus, which is in the class of viruses, cold viruses, and we've all seen the pictures. Now, there's all viruses have genetic material, either RNA or DNA. This is an RNA virus, which isn't of any great consequence. It's very small. It only has 25 genes. Now, here's some practical stuff. The virus is composed of a fatty protective coat and then the genetic material inside. Well, if you try to wash the virus off your hands, let's say you go someplace and you touch it and you rinse your hands, well, the oils are still on your hands, and the virus is in the oils on your hand. So you have to use soap, just like Grandma said. If you want to get the grease off the pans, you got to use some soap. And what soap does, it's partly water soluble and it's partly fat soluble. So it actually, the part that's fat soluble clings to the virus, and then the water washes it off. But it takes about 20 seconds of washing all the surfaces on your hands, in between your fingers, etc., the happy birthday thing, to get it off. So then people figured out that alcohol will do it much faster. It just dissolves. It's a solvent, right? So it dissolves the fatty layer. And so I don't know. I mean, which is better? I mean, I'd rather not put isopropyl alcohol on my hands all day long. It is toxic if you drink it. So it's probably toxic to some degree when you put it on your hands. But if I could do something that takes, with a child particularly, that takes 5 seconds versus trying to get them to the sink and wash their hands for 20 seconds, I think the alcohol is more practical. Mm-hmm. And also another thing that destroys the virus is heat. So that's why they thought that in the summer things were going to get better, because the virus doesn't survive very long outdoors. But turns out we're outdoors and together a lot more, and that probably overwhelms that factor.
Before you move on, I want to show. I forgot. I think I had told you about this. So it's called Briotech, and it's hypochlorous acid. And this was developed. So hypochlorous acid is what our white blood cells make, and they go in and they phagocytize bacteria in our bloodstream, which means they basically eat up the bacteria and kill them. And so this was isolated by a company in Seattle. And so they made it so that it's stable in a bottle. And this is so it's been shown to kill other coronaviruses. Nobody can get their hands on this particular this virus to test it. But I have extrapolated that this, most likely works for this virus. So this is what I carry around. And this was originally developed for wound healing and burns. So you can use it, and my cousin Tim is on here, and this is what I told him to order. But you can spray it on your face. It's completely safe, and it is, you can, if you get it on your eye. So when sometimes you leave a place, I just will spray my face and I'll spray my steering wheel and whatever else I need to spray. But this is, it's a really good, you don't want to just spray everything all the time. You want to spray what you need, because we have bacteria on our skin that we need. We need a certain balance of bacteria. So anyway, this is another nice option for people to be able to use. It's called Briotech, Briotech. And you can order it online, and we have some in our office. Like for those of us who are in our practice, you're welcome to call, and we have some bottles left. But anyway, okay, I just wanted to add that one in there, please.
Okay. So one of the big mysteries has been why are children not getting infected? I mean, they're clearly being exposed. I mean, we're all being exposed. We'll talk about that a little bit more in a minute. But kids just tend not to get sick unless they're little teeny babies. And so we know that the virus attaches to a receptor on the surface cells of the nose and bronchioles called the ACE2 receptors. And about a month ago, a paper came out that looked at the number of ACE2 receptors by age in people's respiratory system, in their nose. I think it was just in their nose, actually, in the study, and found that it was very age dependent. We get more and more ACE receptors as we get older, all the way up into our late years. So presumably we're all exposed, but some of us aren't as fertile a ground because there's not that attachment receptor for that spike protein on that mean-looking coronavirus to attach itself to. So unless it can attach and get into cells, it's not going to make you sick. Which brings up the concept of what you may have heard of a number called the R0. The R0 is a mathematical way of expressing how infectious something is. And one of the most infectious diseases known is measles. It has an R0 of 12 to 18, which means that every person who comes down with measles is going to infect about 18 other people. That's what that number means. Well, with COVID-19, people debate it's somewhere between 1 and 4, probably close to 2 to 3. So unless we stop that transmission, it's going to just roll through the susceptible population pretty quickly. And until enough people are infected, once you're infected, and presumably we're going to have immunity after we're infected, once we get up to about 60 to 70% of everybody infected, we reach the point of herd immunity. So the virus is a parasite. It needs us. And if we're immune or we can't be infected, then it just disappears, just like the previous really mean coronaviruses like SARS and MERS and other viruses. As far as what this germ can do to us, it's mainly a respiratory germ, and it can cause pneumonia. There's this horrible syndrome called adult respiratory distress syndrome. It's very much like what babies get, premature babies. Their lungs just become very stiff, no surfactant. The cells that have the ACE2 receptors make surfactant, the detergent that makes our lungs much more expandable. And so literally, we saw those horrible pictures of the Italians saying, I can't breathe. They literally, their lungs are so stiff they can't breathe. So their only choice is a ventilator. Yeah. And then there's this whole immune thing, somewhat like what kids get, and it's all over the body. The cytokine storm. And then in children, about 4 to 6 weeks after the infection, the multisystem inflammatory syndrome in children. That's a late manifestation, but very rare. Let me emphasize, very rare.
Yes. In that, I may inject there a minute, and that's where integrative medicine, we don't have randomized controlled trials for this, but this is where my big push is for, let's talk about nutrition, let's talk about the things that we know are really good and healthy and support the immune system. Because we also know that people who have done poorly with the coronavirus are people who have lower vitamin D levels, people who have these other comorbidities like obesity and cardiovascular disease and things like that. So when we're talking about this inflammatory storm, if we keep our systemic inflammation down, potentially we have a better ability, our immune system has a better ability of weathering this virus.
Yeah, and that brings up a good point. Why is obesity such a big risk factor? I mean, they're finding it all cross ages, young people, middle age, and older people. And I got to give it to the integrative people. I mean, you guys have been talking about this for a long time, and everybody else is poo-pooing you, but it's turning out that you're, as always, generally right about most things.
Did my cousin Tim hear that? I hope.
There's inflammatory substances that come out of fat cells. I get that's my understanding, and a lot of that has to do with processed food, because people overweight tend to eat a lot of processed food because it tastes so great. And so, I don't know, chalk up another one for the integrative people, I think.
Well, we also 35 per the stats, because I was just editing this portion of my book, but 35% of the pediatric population is overweight. Yeah. So, that's I think this is another good wake up call that the fast foods and all of that stuff is super yummy, but it's really taking its toll on our health. And it's something like this that makes it really hit home. While we're on this topic and about how it impacts us, we've gotten several questions, before the webinar, and right now we're getting you writing in about asthma. And that the study that Dr. Smolen was talking about that looked at the ACE2 receptors, that are in that's where the bacteria is really taking hold, are the receptors in the nasal passages. And that was done in kids with asthma. And right now, kids with asthma aren't necessarily in a higher risk category. So the biggest thing is keeping the asthma under control and keeping this is where we absolutely do the best of integrative medicine and conventional medicine. If your child needs their inhaled steroid, you absolutely use it. If you need your antihistamine, you use it. Whatever the child is on that keeps their systems at bay, and then in the background, you're working and you're keeping their foods. You want to do good, high nutrient dense foods, so more green leafy vegetables, and the green leafy vegetables are going to have magnesium and antioxidants and phytonutrients, and those fruits and vegetables, and lessening things like dairy, processed foods, and doing the healthier fats. So because we were just talking about asthma a little bit ago, and it's, is it safe to send kids to school in the fall for kids who have asthma? And I think if you have them well controlled and you've been working with your doctor and you have your asthma action plan and you understand what to do, I think you can work through this just like all the other kids. And do you agree with me on that one?
Yeah, I do agree. The fall is a very high risk time for people with asthma because ragweed and it's the beginning of the viral respiratory season, especially RSV. And we know there's something about RSV that's funky with asthma.
Right. The flu and RSV are other things to be careful with.
Yeah. And now we have a new, potentially lower respiratory virus. But so far, and spring is a bad time for people with asthma as well. And it wasn't that bad, in terms of COVID for kids with asthma. And so it's not considered a major risk factor, not like obesity is.
And we've also been sequestered, right? The kids haven't been around each other, so they haven't been getting the normal viruses that they often do. Yeah. So I think kids have in general, a lot of the pediatric offices were really slow for a while, not only because they were social distancing, but kids weren't in school. When kids aren't in school,
they were getting hurt, but they weren't getting sick.
Yeah, they weren't getting hurt either.
When they get hurt, they need to go to the emergency room.
All right. I think you have more on your, um, oh, testing. Okay. So we're going to talk about testing now. And again, we're going to get back, we're going to go through more questions because I see a lot of questions, but some of these I'm hoping we will be answering as we're talking through this. And so do you want to talk about testing? Because there's so many variables in testing and so many different ways to test.
Yeah,
And
yeah, it depends on what you're looking for, and there's differences in the test accuracy, et cetera, et cetera. So one thing I learned, big thing I learned from hearing the infectious disease experts talk the other night was that point of care testing, that doctor's offices, urgent cares, et cetera, rapid testing, point of care, is not as accurate as traditional laboratory testing. And there's probably lots of reasons for that. But the tests that the hospitals have are better tests. Now, they're very, very accurate, most of them. The FDA wouldn't let them be used if they weren't. And there's a number of different types. We can look for the virus. The gold standard is culture the virus, but it takes weeks to culture viruses. It's very expensive, and it's just not practical.
explain what that means, just for people.
So you take a sample, and viruses live inside cells. So they're inoculated on, I don't even know what type of cell they use for this, but you can tell when a cell has been infected by a virus, and they can actually quantify the amount of virus, and that's the gold standard of looking for viruses, culturing it. The next best thing is a PCR test, which is looking for the gene signature. So it's like looking at finding the footprints of the criminal. I mean, only that criminal had those footprints, and you got them. And they have ways of amplifying the gene, so you don't need many viruses to be actually able to detect the viruses. So those are the most accurate PCR testing. Then there's antigen testing, where you're looking for something on the surface of the virus, and those are pretty accurate. Unfortunately, in Charlotte, we have about 1 in 4, in some populations, we have as high as 1 in 4 people walking around shedding virus. Most of them are asymptomatic. But when you walk down the street, or you get on an elevator, or you go to the grocery store, you really have, 1 in 4 in some populations. The last hospital numbers I saw, they put them out daily. We'd gotten up to 15% of the tests they were doing were positive. Whereas early, back in March, it was 6%, 7%. So it's been gradually going up.
Mm-hmm.
I guess you could say, well, that's good. We're going to get the herd immunity thing faster. The more people who carry it and get sick and have immunity, but a lot of people are going to really get sick and suffer in the interim. We're hoping that we can slow this down till we get to some treatment or a vaccine or some prevention.
Mm-hmm.
But that 1 in 4, it gets my attention.
Yeah.
I saw a question about herd immunity. How close are we? Baptist Hospital, Wake Forest University, my alma mater, they're doing a survey. They're sending cards for people to do blood specimens looking for antibody testing. And they're up to 14% in their sample last week. So we got to get to 60 to 70% before the experts say it's going to stop spreading around in the community. Unfortunately, it looks like this summer we're going to bump up sort of fast. We had been down at like 2 to 4% all spring. Now we're at 14%.
Which is a good, and we're going to talk about this when we talk about the vaccines also, but about because there are some people who recover, and they're they're the super producers of the antibodies that actually neutralize the virus. So that's where you've heard of people using convalescent serum, which is you synthesize out these antibodies from the people who have survived, and that is very, very effective. But then you're giving somebody a blood product, which always carries a risk with it. So a couple of other things I wanted to say about testing is that it also depends where you're testing, and the sensitivity and the specificity of the testing is dependent upon where you take the specimen. So what we learned the other night is that the place with the highest viral load is the way back of the nose. It's called the nasopharyngeal area. So there have been a lot of memes going around about, what was the other one? One of them was about, I can't remember what it was, but anyway, like, why do we have to put the nasal swab so far back? But that's where the highest viral load is going to be. So we're going to have the highest chance of picking it up, because you could get in the nose, but if you don't get part of the cells that have the virus in it, you're not going to, it's going to be a negative test. So that's just another one of the reasons. And then in terms of the blood work and do we know if we're immune, is nobody knows right now. And it doesn't, so what you can do, it's called titer testing, and you draw blood and you look at an IgM titer, which is more the immediate. That is usually elevated when you're in the middle of the acute illness, or you have IgG titers. And those IgG titers are what come up when the illness is resolved, but for a lot of diseases means you're immune to it. But it's not, at this point in time, we don't know with this virus. We don't know, and for a lot of different reasons, but there are also many different coronaviruses. So if we're checking these titers, is it really to this SARS-CoV-2 virus? Which virus are we actually testing?
Right. The interpretation of those serology tests are fraught with danger, and people don't really know how to interpret them yet. Hopefully, some geniuses are going to figure that out. Which I wanted to add one other thing. You see people walking around with masks, and I'm very much in favor of people wearing masks. It's been proven to, greatly reduce the transmission of the virus. But you just told us that most of the germ is in the back of the nose. And how many people do you see walking around with a mask on their mouth, but pulled up under their nose? I mean, why bother? I just want to just shake, I mean,
Our infectious disease doctor said that half of what she does all day long is educate people on how to actually wear the masks.
Yeah.
So it's, the people we've been talking about, is it harmful? Do you not get oxygen? I mean, neither of us have seen studies that show you don't get oxygen from wearing a mask. And surgeons wear a mask. It's, do you want your surgeon to come in and be operating on you without a mask on? And surgeons wear masks for hours every day. And it's none of us know how little kids, I can't see little kids wearing masks. But we're going to show a video in a minute of what happens when you have a mask on versus when you don't have a mask on.
Well, I'm not so sure that little kids wouldn't wear a mask. I mean, they certainly do it in the Asian world. I think under 2, it's going to be almost impossible to get a child to wear a mask. But, I mean, you're persistent enough, Johnny stops arguing about the mask, I mean, he starts picking at his sister instead of arguing about the mask. Masks are effective. I mean, Taiwan has just got a total handle on this pandemic by everybody wears a mask. And, the point about masks is that they don't protect you so much from getting sick. They protect other people from getting sick. So your droplets, when I'm speaking right now, there are droplets of whatever coming out of my mouth. They're going to aerosolize in the air and they're going to float around for a while. Well, if I have a mask on, those droplets can't get through the mask. And so there's no aerosol floating around me. So it's not protecting me, it's protecting the people around me. So think of it as protecting the people around you. And I think everybody would want to protect the people around them.
It's those N95 masks are going to be the ones that protect us. But hey, I'm gonna pull up. We have a video that we're gonna play. Will you pull up, if you can, on your computer, I never got to your blog. I also want to show the Petri dishes from the blog that you wrote.
Okay.
All right, I am going to share my screen.
Technology on the fly. Can you believe this?
I know. I'm sorry. I didn't mean to.
You're dragging me into the 21st century.
I didn't mean to throw you into a tizzy.
Stressed now.
I know. You are doing amazing.
Yeah.
Okay.
So here it is without a mask. Now I'm recording.
I'm gonna wait. Let me. So this is a physician. The YouTube channel is called Medcram, MEDCRAM. At my office, we all love this. We always say that this guy is my boyfriend. So he does really good, just short videos. It's all research based, and this is where they do this immunofluorescence with wearing a mask and not wearing a mask. So they just, right now it's in the dark and the first person doesn't have a mask on, and then we'll show the second person who does have a mask on. But I encourage you all to look up Medcram. It's sort of geared towards physicians, so sometimes he uses some of the medical words, but most of the time it's anybody would
Stay
be able
healthy.
to.
Great. Stay healthy. Great. Less loud. Stay healthy. Good. Are you recording?
Yeah.
Stay healthy.
Louder.
Stay healthy.
Louder.
Stay healthy.
Nothing.
So you can see perhaps why the CDC is recommending when.
Okay. Doc Smo, how are you
Yeah,
feeling
I'm gonna.
technologically?
Well, I don't know how to share it on Zoom, so I'm going to send this to you real fast, and then you can open it up and you can share with them. Okay?
Yep.
How about that for technology?
I'm fully impressed.
Got to write an email here. There you are. Okay.
And so what this is that we're going to show you is, so Dr. Smolen writes one blog every week. They're packed with great information. And again, it's docsmo.com. And there's a researcher that he just shared on his blog. It was the pictures, and I'll let you tell the background of it while I pull it up.
Well, he's a microbiologist, and he did experiment with a mask and without a mask, and he did various activities. He just breathed, and then he talked, and then he sang, and then he sneezed, I think. And you can see the increase in droplets from these different activities, which a mask really blocked. Can you pull up that visual to show them?
Yep.
Or you can go to my website and just go to that post and do it. But I sent you the link.
Oh, here. Okay. I thought you were sending me your website. Yeah, I can share it.
Yeah, I put it in a post, 5 ways to protect your kids from COVID-19. You might be interested, if you're interested in this webinar, you might be interested in that post. So you can see that on the left, there's no mask, and on the right, there's mask, and then he's got those activities, and look what a sneeze does, man, whoa. You know, which we know. I mean, I think sneezes go like 27 feet or something.
Yeah, so one sneeze, singing, talking for a minute, there's a little bit of growth on the mask.
Yeah, there's a little bit.
Cough. And this is bacteria, not viruses, but bacteria is, like Dr. Smolen said, it's even a little bit harder. Viruses spread often more quickly than bacteria.
Yeah, much smaller.
And so here, this is all this, it's just a little bit bigger. So we wanted to show that to kind of bring that point, to make that point about masks. And I just want to clarify, because what you had said, Dr. Smolen, is that a mask doesn't protect us, but it protects somebody else. So do you want to explain that further?
So the way people think it happens is that these droplets, when we talk or we sing or we just breathe, there are little respiratory droplets that are leaving us. And those droplets either directly infect somebody else if they're infectious, or they aerosolize. They become vapor, basically. They dehydrate, but the virus is still there and it lingers in the air. And we know that's true with measles, and it's probably true with COVID-19. The experts keep debating this. They even debated it the other night. But I think there's not much doubt that this is an aerosol and droplet spread disease. And the mask captures the droplets, so then you don't get the aerosol or the droplets to other people. It's not protecting you, it's protecting the people around you.
And to the way protect, so the people, when we need to be protected, so who needs to be protected? If people in close contact with somebody who has it, and that's where the N95 comes into play. So if I'm, as a pediatrician, going in to treat a patient with it, I need the N95 so that I'm not getting exposed to it.
Right, and eye protection too. We know that eyes are a way it's spread. And remember, half people walking around have no symptoms, and 1 in 4 people currently in Charlotte, last week, in certain populations, were shedding. So it's all around us.
Yes.
And
yeah.
that's what we're finding. That's why so many people are getting sick.
Yes. So I think this is a perfect segue to and so the other point about little kids and masks. So I think one of the things we really wanted to stress tonight is that it's very rare in kids. It's rare for kids. Kids may get it. It's much more rare. And if they get it, they're not getting extremely sick. And so if the little kids will not wear masks, I think that that's going to be all right. I don't think we have to get extraordinarily excited about that. And if, as we get up into the older teenagers, teenagers are also, middle school and teens are where those are a higher risk category anyway, because they're all together all the time and they're very close. And that would be the population where masks will be more important.
Yeah, I think we have experience. All we have to do is look across overseas, China and Europe. They're ahead of us in all this, and they've not had big outbreaks in schools. They're being careful about reopening schools, but they're not having big outbreaks. And I just saw a question pop up. What's a small kid? Under a year is a small child. Beyond that, the incidence of sickness really drops off. You saw those numbers we showed you before.
Yeah. And I think earlier I saw somebody ask, so if there's a baby in the house or a child under 1, is it safe for the other kids to go to school? And that's again where I think we have to continue, we have to continue living. And I don't think we can all stay sequestered in our houses, because our mental health and all the other things are going to get worse. So it's similar to how you would treat it, what's happening with the flu. And this is also where I think integrative medicine can shine, because you want to keep your immune system as strong, keep what you're eating healthy, so that you keep everyone at home healthy. And we just be doing the best that you can, washing hands when you come in the house, all that sort of thing.
Yeah, maybe changing your clothes. Clothes are a fomite. I learned that the hard way with my kids. I'd come home from work, and then, for a while they kept getting sick, and I realized, I'm picking them up and they're licking me and they're getting sick. I start changing my clothes, and they stop getting sick. Remember the point I made before, which was that adults tend to make kids sick and not kids making adults sick. And only about 5% of recognized infections are asymptomatic in children. So that's really good news, because, if you have one child in the family who's got some symptoms, then you want to isolate them from that baby, right? You're probably not going to be able to get them tested.
Yeah.
So that's where your isolation kicks in. Same thing's true with grandparents, particularly with grandparents. If Johnny has a day where he's not feeling well, he's got a dry cough, or he's, got a fever, you really want to keep him away from high-risk people, which are little babies and elderly.
Mm-hmm. Yeah. There's a couple of other questions. So what are your thoughts on possible transmission during middle school and high school students in classes like PE and band where masks might be difficult to wear? Yeah, I think it's definitely going to be at an increased risk.
My guess is they won't have band.
Yeah, that's exactly because
I mean,
all
you
those
blow in
things.
an instrument, you're blowing it all. My
Yeah.
son's a professional musician, and his symphony's been canceled, at least till next spring. So no
Oh,
getting close together, no blowing in instruments.
all right. Let's go on and talk about vaccines.
Okay. So everybody's probably heard there's about 150 vaccines being tested. They're all, the holy grail is to find something that will stop the spike protein from attaching to the ACE2 receptor and starting the whole infectious disease process. Traditional vaccines, what you do is you grow the virus in a way, and hope that it weakens as you grow it, and then you give that weakened virus, which still has the same surface characteristics, but is not as virulent, use that as a vaccine. That's the way flu vaccine's made. And then so that when you do encounter the natural influenza germ, you have some resistance. That takes a long time to grow. The production of that kind of vaccine is very slow. It takes about 6 months. And it's not practical. And I'm sure that people are trying that approach, but most experts I read say that's not going to work. So we have these 21st century technology. You'll hear RNA and messenger RNA and DNA vaccines. So what they're doing is basically giving the cells in the respiratory system already the information how to make these antibodies as soon as they contact the germ. So it's the host, the patient, who's making the antibodies, but the vaccine is giving them the information how to do that. And it's an antibody that is targeted at the spike protein. So that's a rapid production, and they hope that they can make a lot of it really fast.
And in which
There's a number of these.
that spike protein has not mutated yet. So that's the other key. So because
Right.
with the flu virus, with the way that technology, because it mutates so quickly, we don't know until the end of the season how effective that particular flu vaccine is going to be that season. But
Well, often flu vaccine works at the beginning of the season, but doesn't work by the end of the season because the drift in the virus genes, as it moves through the population, it changes.
Mm-hmm.
The moving target.
So
that was the vaccine approach. And then there's let's give people somebody else's immunity. That's convalescent serum or monoclonal antibodies, or they're now thinking they can concentrate the convalescent serum into what they call hyperimmune globulin. Sort of what we did with measles back in the 60s. If there was a measles outbreak in the community, this is before measles vaccine, they lined the kids up and we got a big old fat shot of gamma globulin in our rear end, which was the antibodies from somebody who had already had measles, and it protected us for a while. And that's what COVID hyperimmune globulin is. And you're going to be hearing a lot about that in the upcoming few months.
And that's because a couple of the questions in the chat box were about, how long are you immune after you have it? How long are we immune?
Nobody knows.
And that's the hard part, is that we just don't know. So do you want to talk a little bit about how we were talking about the monoclonal antibodies, how those medications are being used for certain diseases, and it can be very effective, but you have to continuously get them.
Yes. So all those things you see on TV, stop your psoriasis, you got Crohn's disease, you need, Humira, whatever. Those are monoclonal antibodies. So you're interrupting the disease process by attacking one of the inflammatory substances that's driving it. And these are made in a test tube, and you can make them pretty fast, and they're very safe. They are immunosuppressants, so you make people a little more susceptible to other things. You're letting their guard down, but you're stopping the process. So that's another one of those great hopes that maybe we could give healthcare workers and frontline workers and ambulance drivers, and, at-risk people and sick people, these until we have a vaccine that can actually really make them immune.
And then some of the other treatments. So for a while, right when this came out, hydroxychloroquine was being used, which is an old anti-malarial medication. But then there was a study that was happening, and they actually found that it was potentially making people worse. So that was pulled as something that is being used to treat it. And then there's the antiviral remdesivir, and that is being studied now. So that's just an antiviral medication. And then I think the dexamethasone, I think that was in England. So dexamethasone is an old steroid, and we use it in kids to treat croup. It's a potent anti-inflammatory, and that was shown to really help with the acute respiratory distress syndrome. But again, these are things of patients who are very, very sick. These are not things that we're going to need to use in kids who are, just getting the disease and that it's not very serious. And then the immune or IVIG, that's another potential. So that's an immunoglobulin, which and that's what it would be given IV. And that's something now, just to talk briefly about some of the integrative things. Like one of the things that I use often with integrative medicine are immunoglobulins. So it's basically what they do. It's, I think about colostrum that's in breast milk. And the product that I use, they take the serum of cows and they synthesize out the immunoglobulins. And I use that one because so many of the patients in my practice have dairy allergies or dairy sensitivities. And so this one is not, if you have an allergy to beef, you can't use it, but it is, you get the immunoglobulin. And what this has been shown is that it helps to bind viruses and bacteria in the gut. And I use one supplement, but there's also a prescription food that I use. And that's just a little bit more potent. And that's been FDA approved for things like diarrhea, but I will use it also for gut healing and to help keep kids healthy. And we will send around the handout that we created right when this coronavirus hit, of just things to support the immune system. And again, I can't say that this is going to prevent it or to treat it, but these are the things that I'm using in my practice, I'm using with myself and using in our practice with our patients. And it's like quercetin, zinc, vitamin C, the immunoglobulin, and and then we have our foundational supplements that we use. And Dr. Smolen, you had told me about I don't know if it was a study or just the healthcare workers in Turkey who were using quercetin and zinc.
No, quercetin and vitamin C.
And vitamin C. Oh, I thought you said zinc.
Some were taking 500 milligrams, others were taking 1,000. So far, it hasn't been peer reviewed and really put under the microscope. But from what I could tell, it didn't look like that anybody was trying to sell anything in this study. And so far, none of their healthcare workers have gotten infected. Well, we have, I think, thousands of healthcare workers who have gotten infected.
Yeah.
So maybe there really is something to that. Which
I would love if we actually, nowhere in any of this does anybody talk about nutrition. So this is our supplement guide. So we'll email, many of you probably already have it, but we'll send this around afterward. And then these are just the foundational supplements. So we will send that around. And I think, are we through our outline?
Pretty much. I think we went through most of it, the bulk of it. We probably should talk, sort of wrap it up in terms of conclusions and then address people's questions.
Yep.
So The big conclusion to me is despite large outbreaks around the world, we're talking about tens of millions of people now. Fortunately, very few children have died from COVID-19, and very few are really even ending up in intensive care units and in serious health conditions. Almost all of them recover. Number two, an extremely rare syndrome, that MIS-C syndrome is triggered by SARS-CoV-2. They're pretty sure that that's true, but it's treatable and it's rarely fatal, and it's very, very rare, even though you're going to hear a lot about it in the news. It's very dramatic. And then finally, except for major disruptions to children's lives, COVID-19 has not had a serious impact on their health for most children. And we're going to have to just work our way through the whole school thing. There are a number of places around the world that they've reopened, but they're not in the midst of a growing epidemic or pandemic. They had a better control of their pandemic. So how it's going to go in the United States, I don't know. But if we socially distance and mask and hygiene, all the things that we know, I think we can do it.
Yeah, I do. And I think it's time. I think we're going to have many crazy people if we don't start opening up again.
Yeah.
Okay, we were Dr. Smolen, thank you. And if you have some energy left, we'll just go through.
Yeah, we can take on some of these questions. Yeah, sure.
Okay, awesome. And I'm going to also
59 people listening. We got to address the
it makes us excited. He and I sit on and talk about this stuff all the time. It's great that other people are interested. The other thing I'm going to put, so Catherine, after this, Catherine will send around the recording. So don't worry, you will have access to this. And then I also, for any of you who want to learn more about integrative medicine and how to keep your kids healthy, I have an online course that I just put the link to that in the chat box. And I have a book coming out, but it won't be out until fall of 2021. But Dr. Smolen has 2 books out. You want to say the names of your books?
Sure. My latest book was called Great Kids Don't Just Happen. It's really a psychology book about what I've noticed over my 35-year career about which families, what produce the healthiest psychologically healthy kids, and what parents need to provide, in my opinion, and what research says for their kids to have them come out to be great kids.
And it was, there were 5 main tips, right?
Well, there's,
I mean, it's a whole book, but
the whole book. You gotta
I
read
didn't
the
mean
book.
it like that, but I meant, because that was the thing when you told me that. I was like, just tell me what those are. But you said you have to read the book.
No, I'm not going to give away my secrets in my book. People have to read my book. And then the other book was called Can Doesn't Mean Should, which was, we've got a generation of parents who can provide a lot of things for their kids. I mean, more than any generation of parents have ever been able to provide. But should they? And so I went through the evidence with nutrition and technology and chores and extracurricular activities, and I tried to ferret out as much real information about how these things affect kids and help people make decisions about how much they should provide for their kids. Where's the line? And it's going to be different for every family, right? I mean,
Right.
so if you've got a musical genius in your house, you're going to want to provide a lot more of that kind of stuff for them. But I help people think through that whole process.
Yes, very good. And he is the practical one. Okay, so I'm going to go through one question. This is a tough one. So this is from a mom. I found out I tested positive today. I have 5 children and have isolated. Do you think it's worth isolating after being around them this whole time?
Yes. Yeah, the recommendation is that you isolate any sick person, that everybody mask in the home. I mean, they've even looked at that, where somebody gets COVID-19 and they don't wear masks, the other family members and the index patient, versus people wearing masks in the home, and the outcome was much better if everybody wore a mask.
And so the numbers also, it's how long we're not really sure exactly how long people are contagious, but if you've had it, you definitely need 10-ish, 14-ish.
Well, I heard 10 days. I always thought it was 14. The self-isolation thing was 14 days when people were exposed, but I heard loud and clear the other night, 10 days.
Yeah, I have to say though that if somebody were exposed, I don't think I would want to be around them in 10 days. I think I would want a little bit longer, because you can also shed the virus in your stool. So you really need to be careful in bathrooms. You need to be careful in washing hands really well.
And close the lid on the toilet before you flush, because apparently poop aerosolizes.
Are you gonna, maybe you'll do a study on
I'm a
that.
pediatrician. You got to do poop talk, right? That's all we do is poop talk.
All right, and here is another one. If I, as a parent, have pre-existing medical condition, example, high blood pressure and high cholesterol, and I'm able to continue to work remotely, wouldn't I also be putting myself more at risk by sending my children to school? While we don't have control over the virus in the US, I agree that kids should be back in school, but there are cases where kids or parents at risk would be the exceptions to be weighted. I have 4 kids in lower school.
Well, again, route of spread is generally from adult to child, not child to adult. If you want to mitigate all your risk as much as you can, I mean, they do go other places. Even if you don't send them to school, they may go play with their friends, or run around the neighborhood, or go to the grocery store. So you can't take all the risk off the table. But if you have the option of working remotely, I think that would be what I would probably choose to do.
Yeah.
You got to balance that with your kids' needs, their educational needs.
Yeah. And then, Beth, hello, Beth. Should we take our children into the doctor for their well checks with all that is going around? I have a child that's about to turn 6, but I'm worried about taking her in for a yearly well check.
Well, they're doing a lot to prevent the spread. They're all wearing all sorts of stuff. Anybody who is in any way sick is being isolated. The rooms are being fumigated. They're taking great precautions. And the flip side of that is, if you don't get your immunizations and you don't get your preventive care, I wrote a post about this one, there's a lot of bad things can happen to you there. What if you have a child who has growth hormone deficiency, who has hypertension, or doesn't get immunized and comes down with measles, or, so again, life's not black or white, it's gray. But generally speaking, I think you should get routine preventive care. It's valuable.
And I think also, Beth, you can make that judgment based on the age of the child and how the child's underlying health. And I do think with your sweet kiddo, it's probably a good idea to go in to get your well visits to keep on track. And in some ways, I think the hospital and doctor's offices right now may be cleaner and safer than they've ever been, because people are paying a lot more attention to this, and they're cleaning and they're, all the toys have been taken out of most of the offices, and there's, we're taking away the things that allow the spread.
Yeah, my old office, they have a special time for babies to come. They group them all together, so only babies are in the office.
Mm-hmm. Mm-hmm. And then a question about asthma, which I think we've answered, Marilyn. And my 7-year-old daughter has mild asthma. Does that put her at higher risk category and therefore more risk to be at school? I think as long as your asthma is well controlled, you're doing the medications that you need, I think she would be okay. When you get into those kids with really severe asthma, that's definitely a discussion to have with your pediatrician or your pulmonologist or allergist. But I think if it's mild and it's well controlled, I think you just do all the precautions that we've been talking about.
Yeah, asthma does not pop up on the high risk radar.
Mm-hmm. And then Ryan asked, what are your thoughts on aerobic activity without masks, like children's dance class?
It depends on how close you are to other people and when they were in the same space, how long ago they were in the same space. If you're outdoors and you're well distanced, I have absolutely no issue with that.
Yeah, and I know somebody who's listening had their child had a great little dance recital. It was all outside, and the kids were all spread out, which I think it was, perfectly safe. So, lots of questions about masks, and I think we covered that to the best of our knowledge and the best that we could. Is the
Cover
virus
nose,
transmitted through?
multiple layers.
Yeah,
Cover
yeah.
the nose, multiple layers, as tight as you can get it. Wash the mask.
And then Eileen asked, you said children have less ACE2 receptors and the highest viral load is far into the nasal cavity. Are kids going to transmit coronavirus to other kids or teachers in school without a mask?
They're much more likely to do that, I think, if they are infected.
If
Yeah.
they're infected, yeah. Okay, and then somebody did ask about the death rate in kids, and it's very, very low. I think it was 0.69.
Yes. But that's 0.69 of a very low number, right? It's very low.
Yes, yeah. And again, your child has a higher risk of dying of many other things other than COVID. All right, I don't see, COVID more than once. Okay, I have read where people have caught COVID and had it more than once. I have also read that the antibodies may be short-lived. How will a vaccine work if this is true? Well, I think you covered that.
Yeah, there's a lot of unknowns about all that. And just having a positive test doesn't mean the virus is alive and doesn't mean you're infectious. So there was a lot of chatter about people who were recovering who continued to have positive PCR tests long after their illness. But then I think it was determined that most of those people were not infectious because when you went to culture those viruses, they didn't grow. Even though you detected them, they didn't grow. They weren't viable. And nobody knows about reinfection. We're not going to know about that for a few years.
Yeah, for a while. And then Cindy asks, I love this question. So thoughts on the role of the gut as first line of defense against this type of virus, role of adequate stomach acid and the even balance of microbiome. So Dr. Smolen and I talked about this the other night too. There's the gut microbiome. We don't know enough about this right now, but so Dr. David Perlmutter, he's a neurologist who's phenomenal, and for a while he was doing a live Facebook update every day. I was listening to a lot of his, and he started looking at what are the rates of COVID in some more developed countries. One of them was Haiti, some were in some African countries, and where the rates were extremely low. And his theory was that they have such a microbiome diversity, or the bacteria in their gut is so diverse that potentially that was protective. And there's also a lot less travel in and out, internationally in places like that. So there are many different variables. But certainly from an integrative perspective, keeping one of the very first lectures when I was doing my integrative medicine fellowship, one of the first lectures that Dr. Andrew Weil gave us was about breathing, and then it was about stomach acid. So one of the number one over-the-counter selling medications are antacids. And we need our stomach acid because that is what it activates our pancreatic enzymes. Our pancreatic enzymes are what break down our food. They help us to break down our fat so that then it goes into the small intestine and gets absorbed. So if we're on a PPI, a proton pump inhibitor, that is going to buffer that stomach acid. It's going to impair our B12 absorption and our other nutrient absorption. And that's going to impact our immune system down the line if we don't have proper nutrition. Now, I haven't seen any research that actually says if the virus goes into the gut, the stomach acid will kill it. I always note those are some of the proposed mechanism, but it's mostly, to me, you want good stomach acid to make sure that you're digesting and absorbing your nutrients properly.
Well, once again, the integrated people put another check mark in the column, because yesterday a large study came out looking at PPIs and COVID-19, and it was dose related. So there were people who took none. There were people who took H2 blockers, which block some acid, but it's very weak. There were people who took 1 dose a day of a PPI, and there were people who took 2 doses. And guess who did the worst? The people who took the most, so isn't that Cook's postulates? Isn't that one of Cook's postulates?
And actually, now that you say that, Virginia sent me that post on Instagram, and somebody had put #probiotics, not PPIs.
Right.
And that's one of the things I do in my practice with kids who come to me who are on a PPI, is we work to safely get them off of it and to, make sure that we're.
Well, we also know that pneumonia that's the major risk of PPIs. The rate of pneumonia is much higher. And this is in older people, but it's much higher in people who take PPIs chronically.
I've seen many, many kids over the years that that have come and they're on maybe an antibiotic every other month or once a month, and they're ear infections and maybe some wheezing and eczema. And we work to improve their nutrition and get them off the PPI, and we're typically able to improve their microbiome, and then we're typically able to stop that cycle of recurrent illnesses.
Yeah.
And then Allison, hello. So this is my friend, and she says, do we know yet if reaching herd immunity is probable? I keep reading that antibodies may not be lasting.
Well, this is a cold virus. Do we ever become totally immune to cold viruses? I mean, we get new colds every year, right? So it's likely that this is going to become a circulating cold virus. Hopefully it's going to be more seasonal, and hopefully it's going to be less devastating, because as we have more experience with it, more people have immunity. But it's not like we're going to reach the 60% and it's magically all going to go away. I think we're going to be dealing with this every season, respiratory season, and it's just added to another one, and it's like 2 to 3 times more virulent than influenza.
Yes, yeah. So we'll take a few more questions. So another one about what are the risks to pregnant women, and it definitely poses a risk, and they need to be treated. They definitely need to be talking to your gynecologist, because it's going to be more limited. If they got serious illness, the way that they would be able to be treated, it would mostly be supportive.
Well, the Academy of Pediatrics put out a statement about, first of all, pregnant moms are usually asymptomatic. The majority of them are. And but then the question is, well, after they have the baby, what do you do with the baby? The mom is shedding virus. Do you put them in the whole, rooming in baby friendly thing? So Academy weighed in on that one and didn't think the baby should be in the room with the mother. So they're always getting into hot water. The Academy of Pediatrics is always getting into hot water about something. That was their latest, I think.
I'm going to try to get them off the dairy wagon.
And then sending them back to school. I mean, they had a statement recently. I haven't read any of those statements, but that's what I've heard.
Okay, so then understood. Well, I think one more question. So a couple more questions. Understood that asthma does not come in the high risk category. What about viral induced asthma? So this again, go ahead. Did you want to?
I think it's probably like every other viral illness. I mean, viruses trigger asthma in some people. The major virus is rhinovirus. That's the number one by far. It's the big gorilla in the room with people with asthma. So we don't know.
Yeah.
But so far, it's not been a big health problem. COVID-19 has not been a big health problem, the severe illness for people who have asthma.
And then, okay, so some of the questions on, there are some questions about masks, psychological effect of mask wearing in young children, any studies, also impacts of wearing masks, and are looking at a masked teacher and learning to read. So I have not read any studies about the psychological impact of kids wearing a mask. Have you?
No, but again, the Asian world is all about masks. Anytime anybody has any symptoms, they wear masks. So if there was some terrible psychological problem from it, I think they would have told us about it.
Yes. So so I have not read about that, and if we find anything,
I have never heard anything about that. No.
We can post about that. And then we'll do one last question. Does a child's history of RSV or pneumonia put them at higher risk of complications from COVID?
So I think the way they word it is you have to have chronic lung disease. So if you have COPD, the architecture of your lung has been severely damaged and it's never going to get better. You have COPD, you can't repair really damaged lungs, and most of those people are going to be smokers. They're at high risk because their lung capacity, their oxygen exchange, et cetera, is really, depending on their age, is very much lower than their age-matched controls. Asthma is an intermittent. Most people have intermittent asthma. They're triggered by things, but they don't have chronic lung disease. And the architecture of their lung is normal, except for they have more inflammatory cells in their airways that are twitchier. They're set off easier. But that has not seemed to be a major risk factor. COVID or SARS-CoV-2 has not been a big factor for them.
Yeah. So I do have one of my patients in my practice right now is an extremely severe asthma. So parents pulled him out of school early on, and I'm super happy that he's a person we've been working with for a while. So the asthma, even though it's severe, it's under much better control. He's still on many medications, but he's one we are going to be extremely careful with, and he may end up staying at home and being homeschooled for this next year. So when you're getting into those more severe cases, those are definitely questions to be discussing with your pediatrician.
Yeah. Well, if somebody had, cystic fibrosis, I would tell them to stay away.
Yes. Yes.
It's a fixed lung disease. And the end result of severe asthma is COPD, over decades, untreated, poorly controlled.
Yes. And Ryan, somebody to ask for the link to the COPD study, the PPI study. I'll put it right. I think I just Googled it really quickly. Increased risk of COVID-19 among users of proton pump inhibitors. I'd say that's it.
But not with the H2 blockers.
But not with the H2. So the H2 are things like Zantac.
Well, they took Zantac off the market, but Pepcid, famotidine, and actually the Chinese thought that famotidine actually helped people with COVID-19. They discovered when they looked at their cases that a lot of people, you have rich Chinese and poor Chinese, and the rich Chinese take the expensive medicine. They take the one that really is more effective, which is Prilosec, and they had much more severe disease. And when they looked at the poorer people, they took famotidine, and they seem to do much better. So people have been wondering whether famotidine could be a treatment and or a prevention. There are actually trials going on right now, big trials, because it's a cheap, well-tolerated, universally available drug.
Yeah.
So
yeah.
The word's not out yet, but maybe it actually, I don't know. Who knows?
Well, and God forbid they do a study where we actually look at our probiotics and zinc and quercetin and vitamin C. I would love to see those trials getting started.
Yeah.
I think it's just the money. It's where the money comes from. The pharmaceutical companies have the money to get these things started, and the people who know how to design a study and collect the data. And we just need, we need more studies in the nutrition side and supporting with supplements. Dr. Smolen, thank you so much.
You're welcome. It's always fun.
This was very fun. I hope you I hope you will get to, we kept him from his woodworking today. So I hope you get back to your beautiful table tomorrow that
I'm gonna
you're,
get there. We held our audience pretty well here, Sheila. Look, we're still over 100 people out there.
wow, people, thank you. We are so excited to have so many people on. And luckily we practiced on Tuesday with our Peds Society meeting. We had over 100 people, and we were nervous about the technology. So
we're getting better at this.
it
was a quick question about, is quercetin, I didn't know anything about quercetin until I read that study. Is it safe? And I don't think there are any side effects on it.
Yeah, no, quercetin is very safe. Yeah.
It's green tea and capers.
It's tough. It's tough with little kids because we don't have it in, like, we've only been able to find it in capsules, and it's going to have a taste if you open, because a lot of the things we use, you can open the capsules up for the kids. But it's just not going to taste great to open it up to give it to kids. But can you make tea out of quercetin? I don't know the answer to that, but yeah, quercetin is very safe, and we have the dosing, and we have the brands that I recommend that will be on that handout. We'll send that handout around when we send out the link to this webinar. And a lot of people have asked when we'll get access to this. So Catherine, if she is around, she may be able to send the link out tonight. Otherwise, we will send it around tomorrow. And I was going to give you one other thing. So I have a website store on my website, and we have a lot of these supplements on the website store that you can grab, like the quercetin and the immunoglobulin, and I didn't talk about it either, but I use it's called a protease, and what a protease is it's a protein enzyme, and we use that as we're working to get people's guts back into shape and to make sure that we're breaking down food, because undigested food is very inflammatory. And we will use these proteases in a little bit of a higher dose on an empty stomach, and they get absorbed systemically. And then they start to, like, when you take it, if you look under a microscope, it helps the red blood cells move a little bit more fluidly in the bloodstream. And that's going to help oxygen exchange. And and we will use that in kids, like if they're getting headaches or fevers, that's just something that we add in. So, all right, very good. And Jennifer, does my handbook talk about the vitamins kids should take, multivitamin? Yes, yep, I do talk about that. I typically use a whole food supplement called Juice Plus. I have yet to find a really good brand of just a multivitamin mineral that I like for kids, but Smarty Pants is one. My preference is Juice Plus, which is a whole food supplement, but Smarty Pants is one, and Seeking Health. Ben Lynch makes some nice multivitamins for kids. Okay, perfect. Thank you so much. Thank you all for listening and staying on with us.
Thank you,
Dr. Smolen, and thank you to my cousins in my family who listened.
Good night, everybody.
Good night.